the session, let's all stand for a national anthem. Sorry for inconvenience. The moderator of the today webinar, Dr. Smita ma'am. Now I request the moderator to please start the session. Thank you.
Thanks a lot. Thanks a lot, Amity. I'll start off with it. Well, without a solid foundation, you'll have trouble creating anything of value. People find each other with both broken foundations and they build together as a team to make a foundation that is indestructible. Namaste to all and a warm welcome. The goal of this webinar is the advancement of knowledge and dissemination of facts. Well, the foundation stone for a balanced success of IAP Bihar branch is Dr. Narendra Kumar Sinha, sir, President IAP Bihar. He is ex-HOD of Physiotherapy and Academic in Charge BCPO, Patna, Bihar. Sir will brief about the legal status and achievements of physiotherapy in Bihar. Please, sir, proceed. Over to you, sir.
Thank you, Dr. Smita. Good afternoon. I welcome to our speaker, Dr. Parveen Kumar, pediatric neurologist, Sir Gangaram Hospital, New Delhi. Dr. Vinay Pandey, Vice President. Dr. Uma Shankar Sinha, General Secretary. Dr. Rohit Sinha, Joint Secretary. Dr. Asmita Singh, State Coordinator, IAPWC, and all the IAP Office Bearer Bihar branch and IAP Technical Cell. I also welcome to all the participants of the webinar. I am very glad at my presence of this webinar organized by IAP Bihar branch on the topic of this webinar. I am very balance and posture. It occurs due to brain damage by various factors during and after childbirth. It is a most common motor disability in childhood, and about 1 of every 300 babies worldwide born with a or a developed CP. It is therefore very important to understand and differentiate CP with other disorders which is not neurological or CP. For this present webinar is really useful. Physiotherapy is quite helpful in improving the quality of the life. Let me tell you little about our professional work for the development of our profession. It is our pleasure to let you know that IAP Bihar is striving hard and taking all necessary steps for the upliftment of our profession. The major issue is to form an independent council at both central and state level. Our persistent efforts are getting an immense support from the different profession and political bodies. We have achieved independent status in the proposed Central Council Act and have been approved by the Central Health Department, Government of India. While our draft in the National Commission for the Allied and Healthcare Profession is 2020 is at ready to be present in the Parliament. But unfortunately, due to Corona, it is getting delayed. We are thankful to Minister of State, the Development, Department of Health, Government of India, Sri Ashwani Kumar Chaube, for carefully assessing our issue and giving assistant support in this regard. In addition to this, we have been putting continuous efforts in the formation of the State Physiotherapy and Occupational Therapy Council in the final stage. While we are working with positive mindset and are quite confident to get success in our effort, we have also been working to ensure pay hike for the physiotherapy professional through pay revision and also ensuring to have more job vacancy in the near future. For this, we have got words from the Chief Minister of the Bihar, and at present, the vacancy are really come out. We at the IAP Bihar branch are committed to continue our quest to gain excellence in our professional development in 2020. My best wishes to the success of this webinar and to all of you. Be safe and healthy. Thanks.
Thank you, sir. We are blessed to have you as a guide. Now, due to a number of factors, movement disorders such as cerebral palsy are often times misdiagnosed. Now, the majority of parents of children who develop cerebral palsy leave the hospital with an initial diagnosis of some form of brain injury, although the extent of the damage is not known. Other parents might be sent home with a vague concept about low ADGAR score and little else. Now, symptoms such as lack of suck and lethargy may send these parents frustrated and worried. Now, back to pediatrician repeatedly, over time failure to meet developmental milestones leads to a diagnosis of cerebral palsy. We are fortunate to have Dr. Praveen Kumar with us today, who is a consultant pediatric neurologist at Sir Gangaram Hospital, New Delhi. Uh, Sir will be throwing light on what is not CP. As already mentioned, many other conditions can masquerade as CP, but it is essential to understand basics of CP and to identify its mimickers for appropriate management. Now, over to you, sir.
So let's start.
Yes, sir, this is your session, sir, and over to you.
A very good afternoon to all of you. And at the outset, I would like to thank Dr. U.S. Sinha for the and the team Indian Association of Physiotherapists for giving me this platform to come and speak in front of you. As already mentioned by Dr. Smita and Dr. Narendra also, that cerebral palsy can have its own mimics. And my idea of today's talk is that to make you aware of the conditions where we as a clinician or as a neurologist feel that this child doesn't fit into the typical features of cerebral palsy. So he requires further evaluation and further investigations and further management so that these things can be managed. If something else can be done apart from the neuro rehab part to improve his condition, and can we prevent such kind of recurrences in the family? So that's the part. So can you all see the slides?
Yes, sir.
Thanks a lot. So let us start with this case. This child came to me almost maybe around 2.5 years back with an history of seizure. So he was basically sent to me because of his seizure part. And he was already labeled as a case of cerebral palsy. When I saw him, I found that he had something beyond cerebral palsy. He had definitely a dysmorphic faces in terms of coarse facial features. Look at him basically. He had prominent ears, and on inquiry, he had slow attainment of milestones, but he was intellectually also on the lower side. While I was dealing with him, after a couple of minutes, his younger sibling peeped into the room. Look at the right part of the screen. So I asked the mother, who is he? She told that he is his younger brother. He is perfectly fine. Apart from that, that he is also slightly slow in the study, but he doesn't have any other features. So I tried to convince the mother. I asked them that definitely will manage the seizure part, but he requires further evaluation in terms of any genetic etiology causing his slow development, intellectual impairment, apart from the seizure part. So we sent his Fragile X screening, and if you look at the report, it came positive. So both the children, diagnosed for one case, we sent the investigation for one case, but definitely the other child was also suffering from the similar kind of disease. This was a child who was suffering from Fragile X syndrome, and you'll believe me that when I discussed with her when the report came, the mother was more relieved, and she had some kind of repentance also. Relieved because she felt that all through these years of 14, 15 years, she had been blaming the obstetric team, the hospital for the condition of his child, because she thought that this is basically because of some perinatal asphyxia, which is the most common cause regarded, or common cause thought as a case of as a cerebral palsy. So she was blaming the orbital part. And at the same time, she was also thinking that had she known the diagnosis before, maybe she could have prevented the birth of her other child with similar kind of illness, who was also not fully fit. He also had the intellectual impairment. So I think this is my first take home message. The mother herself gave the message which I want to convey to you, that all the children who are supposed to having some global developmental delay, or who are lacking in their motoric milestones and having some intellectual impairment, they are loosely labeled as a case of cerebral palsy, and they are left basically. So once you label someone as a case of cerebral palsy, it becomes a kind of like dead end for them. People don't need to evaluate them further, because they feel that evaluation will not bear fruits, because it will be costing money to them, and it may not improve the outcome in that part, which is not the case. That is the kind of message which I want to share with you, all, that children who have got some atypical features of cerebral palsy, which you come across in your day-to-day clinical practice, they must be evaluated further, because they might be having something different which can be treated, and definitely they might be having something which can be said to the parents as a cause of their child's impairment. And definitely we also want to have the prevention of future pregnancy with similar kind of children in a part. This is not the only one case basically. So the other child also came to me as a level case of cerebral palsy. He was having some problem also. The parents were very anxious because child is not learning. He was getting all the scolding from the school and from the home also. And look at him also. He was also having facial dysmorphism. He's having prominent ears and coarse facial features. We got the Fragile scanning done, and it also came out to be positive basically. So the message here is this is not something which is a rare case. Individually it may be uncommon for general population basically, but if you start looking at them, if you start evaluating them, if you start clubbing all these cases together, so they are not uncommon. So individually they may be uncommon, but once you start clubbing these cases of genetic issues causing CP like features, they are not uncommon. So they're not one of the cases basically. This also turned out to be. And then once you tell the parents that he's not behaving well, or he's not doing as per his peers in the class, it's not because of his own fault. It is because of his genetic makeup, that he is tuned, or he is he is built up like that, that he will have some kind of intellectual impairment basically. So this also gives a kind of like relief to the child also, and kind of relief to the parents also basically, because they understand that he's not studying because he's not concentrating or he's not putting all his effort basically, because but the real reason is that the child is putting all the efforts, but he's lacking in his mental ability because of his underlying genetic issues in the part. And this helps in the therapy part also, because you know that what you aim for. So in these children, you don't aim for that they will become totally 100%, normal, because you know that they will be having some amount of, deficiencies, no matter how much therapy, no matter how much medications and all these things can be done basically. So we can be realistic when we counsel them. We can be realistic when we treat them in terms of our medications or neuro rehab part and all those parts in the part. This child, he was born preterm, he required nursery stay, he had a poor Apgar score, and he had difficulty in walking and achieving his motoric milestones basically. So look at the way he is walking. Definitely he has got some difficulty in locomotion, difficulty in posture also basically. And once you look at his MRI, this MRI has got periventricular subtle signals, like these areas, the ventricles are irregular, and this is the classical case of cerebral palsy because of hypoxic ischemic insult at birth. Both the child and the neuroimaging both are, favoring diagnosis of cerebral palsy. CP is an old term. First, it was described by William Little. He was an orthopedic surgeon basically, and here in 1960s, he wrote a monograph about cases of cerebral palsy having locomotion and posture problems, and he attributed it to perinatal asphyxia. So he found that the cause of basically perinatal asphyxia, and this remained true for many years basically. In fact, you will find that after almost 3 decades of Little's description of cerebral palsy, it was Sigmund Freud, kind of like who was a neurologist, and he had a psychoanalysis approach also. He described CP, and he told that CP, because of his multiple symptoms, not only the motoric locomotion, but intellectual, seizures, behavioral, seems not only because of perinatal asphyxia, but it may be having some prenatal onset of his origin. But look at him. He told him at around 1910. But for many years, like almost for a century, you can find his theory, his concept was disregarded, and it was still considered that CP is mainly because of prenatal asphyxia, because of poor Apgar score, because of hypoxic ischemic encephalopathy, which we now know that this is not the case. Because of very wide acceptance of perinatal asphyxia as a cause of seizures, or sorry, a CP, they were in market electronic fetal monitoring, being used with all the pregnant mothers basically. But despite having a very good quality of fetal monitoring, and because of fetal monitoring, increased rate of LSCS, cesarean section, getting for the delivery of the child basically, in past couple of decades, the incidence of CP had not decreased over time. It still remains 2 to 3 per 1,000 birth. So it means despite having a good fetal monitoring, despite having cesarean section delivery to circumvent the perinatal asphyxia, the CP has not decreased. It means CP is something beyond perinatal asphyxia. It has got some prenatal basis also, and that is the part. And once they have done studies in a large population base, what they have found that the birth asphyxia has been only found in 10% cases of cerebral palsy. So almost more than 90% cases are still beyond birth asphyxia in those parties. And what they found that in children who are not having an acquired etiology, acquired means something which has suffered at the birth or just after birth, in those cases, genomic abnormalities could be a significant contributor to their cerebral palsy-like syndrome. And these genomic abnormalities can also cause cortical malformations. The brain is not well formed. The children who has got genomic abnormalities, their brain are not well formed, and when they take birth, they may fail to cry, or they may go under stress, and they will have poor Apgar throat and labeled as an hypoxic ischemic encephalopathy. But they didn't have the pure HI part at birth. What they had was really an abnormal brain to start with, who could not sustain the pressure and the stress of intrapartum procedure. So the problem was basically prenatal, antenatal. So that is the basic understanding basically. So we know CP is not a disease. It's not an pathological diagnosis. It's not an etiological diagnosis basically. This is a neurological syndrome where you have a common clinical signs of abnormal movement and posture. But the diagnosis is not common basically. There's only the symptoms and the signs are common. That's why you need to identify the cause of a child who is having common symptom of impairment in posture and the locomotion. So what is the specific etiology basically? Because once you identify the etiology, then you may prevent the recurrence of similar kind of birth in the sibling basically. What is basic about the CP? We all know, in detail, a motor deficit is always present. The parents complain child is not reaching his motoric milestones at the appropriate age basically. But the examination, serial examination will tell you, and the history will also tell you that the child is not losing milestones. So gradually he will be adding to his skills only. Once you start getting history, the child is losing milestones, your ears should stand up. You should start thinking this may not be CP basically, if he's regressing basically, if he's going down on the part. And CP typically, because of his location of lesion in the brain, they have typical human signs in the form of pyramidal or extra pyramidal signs basically. And apart from the motoric signs, they definitely have the other issues also like cognition, communication, behavior. If you're having only pure motoric signs, you still doubt cerebral palsy. We'll see in a couple of slides, that's basically. But CP, because of the etiology, definitely they have got some signs which are beyond motoric part. They only won't have the motoric components. They will have definitely some amount of intellectual, learning, sensory, behavioral issues basically. Because when the injury occurs at the at the perinatal part, it involves the other part of the brain also, especially the hypoxic ischemic injury. So depending upon what part of the brain is involved, if it is basal ganglia, you can have movements as the predominant feature. If it is global insult basically, then definitely you will have basically spasticity and quadriparesis basically. If there are multifocal areas, you can have both the findings of spasticity and the dyskinesia basically. But whenever you have got these two things, like the movement disorders like dyskinesia, chorea, and those ones, or if you've got cerebral findings like hypotonia, these are the cases where I will say that you doubt diagnosis of cerebral palsy. If this is something which is a global insult with spasticity and intellect and all these things involved, you still can think of multiple places, you still can think of. But pure movement disorder, pure hypotonia, so doubt about diagnosis of cerebral palsy in these cases. Similarly, if you look at the slide, the C and D, the MRI features which are suggestive of perinatal insult in the form of periventricular leukoencephalopathy, they go in the form of typical cases of cerebral palsy because of acquired perinatal insult. But if you see MRIs like this one, where the brain is not well formed, like in these cases, it's like a very poorly formed brain, cortical malformation basically, or if you find some calcifications in the brain, so you are basically antenatal onset, and you look for the infections like TORCH or like conditions, genetic etiologies, which can give rise to the cortical malformations, and these can recur because they are prenatal onset. This is basically because of perinatal asphyxia, hypoxia. This you may prevent, but this you have to prevent from the proper testing investigation in the part. Coming to our common cases, this young child came to me at around 30 months of age because he was walking with support. He was slow to respond. And when I examined, we found that he was hypotonic and he had rough skin basically. Reflexes were also suppressed. So he was hypotonic with rough skin. We sent his TSS level and it was more than basically 100. I've never seen TSS level in such a high part. It was more than 100 basically. Normally the range is less than 6, and it was diagnosed to be case of congenital hypothyroidism, not uncommon basically. So labeled as a cerebral palsy case, and he was already receiving all those kinds of therapy for that part basically. So the first message is this, that you doubt cerebral palsy in a child who is hypotonic. He requires further evaluation. He was put on thyroid medication and definitely he improved, but definitely he already has got a significant damage to the brain. Had he been picked early, then chances of his having complete recovery would have been much better in those cases. So diagnose CP if a child is hypotonic. Similarly, a young child who is also not developing well came to us as a case of growth development delay, query static encephalopathy, cerebral palsy. When I look at him, basically I found that he is an active, alert child, quite interactive. He was motoric milestones were also within almost range basically. But what was striking was his a very large head circumference and short arms. Look at him basically. The head seems to be prominent, bulging in the part basically. I sent him for the evaluation for achondroplasia. We sent the gene for that part and it came positive. It was basically positive for the achondroplasia. So the message is this: whenever you see a child who has got a macrocephaly, basically, definitely you think beyond acquired perinatal insult. You doubt CP in those cases. Mostly CP because the perinatal syncytial they will have the normal head circumference or they will have a microcephaly part because of the brain insult in the part. This young child came to us from Nepal basically because at 15 months he was not standing. So it already delayed basically on that part. And then he had recent febrile illness and he had deteriorated after the illness. Then he improved. Then again he had febrile illness and then he had become lethargic again. So he had delayed milestones and then he was having a waxing waning course after some kind of febrile illness. We got his scan done and look at the scan. This is an MRI part and you can see bilateral hyperintensities over here in these locations basically. So normally such kind of symmetrical hyperintensities on the MRI in a child who is having some waxing waning course basically is something which is unlikely to be because of the cerebral palsy in the part. So whenever you see a child who is regressing, he's having some intermittent worsening basically with symmetrical MRI findings, you need to think beyond cerebral palsy in these cases. And he was evaluated for the leukodystrophy. It came out to positive from in him. Similarly, a young child, he had some acute GI illness and then he had become dystonic in that part basically. So he was almost well for around 5-6 months of the age, and then he had some GI illness, loose motions, vomiting, and subsequently basically he went down and he had those kind of stiffness and dystonic posture. Look at the way when he's crying, his limbs are basically stiffened basically. So it's also labeled as a case of like acquired cerebral palsy. But when we saw the scan, what we found that he has got very significant hyperintensity in the temporal area, these locations. It's not classical of cerebral palsy. So this tells you that this child has got something before this illness. Means he already has got some antenatal or prenatal brain insult because he already had got this kind of hyperintensity CSF in the brain. So we evaluated him and he was found to be suffering from the glutaric aciduria. And this is manageable because this is an metabolic defect causing metabolic defect of lysine, hydrolysine basically causing glutaric aciduria, and they require a high protein restricted diet and supplements basically so they can improve on the part. So had we seen him before, maybe he could have a better chances in terms of the improving before the other things. Look at the other child. This child has got gait problem. So look at him. This is also a posture problem of locomotion and posture. So he's got definitely locomotory problem and he can't stand in a correct way as per his age. Thought to be because of some acquired brain insult. We got his scan done, but we found that he has got significant bilateral lesions in the globus pallidus, and on further evaluation, he was found to be suffering from the Wilson disease because of the copper deposition in the brain, and that is also treatable because of the you give the copper splitting agent and they improve over a period of time. So you have to doubt cerebral palsy whenever you see a child who has got some neurodegradation. So he was doing well, and then he is going a downhill course. This is unlikely to be because of cerebral palsy in a part. This young child, they also came to me because of his global developmental delay, labeled as a case of cerebral palsy. And if you look at the child, basically you find that he has got some eye abnormalities. He's got some nystagmus in the part, quite active, alert child, and with significant eye abnormalities. The eyes are rotatory. And when we got the scan done, but we found that this child has got basically cerebellar Vermean hypoplasia, what we understand as a molar tooth sound over in the brain. And this was basically suffering from a syndrome which we call as a Joubert syndrome. This is a genetic condition where because of the Vermees, the cerebellar hypoplasia, the child becomes hypotonic and he has got the eye abnormality. The purpose of showing you this, whenever you see a child who has got some ocular abnormalities, the nystagmus, the fixing following part, especially the nystagmus, the obstruclonus part, you think twice before labeling them as a case of cerebral palsy. Although CP can also have the problems with the fixation and the feeling problems, but they have got other spasticity signs also. So especially a child who is having hypotonia with nystagmus, you think about cerebellar pathology, and that is most likely because of some genetic etiology in those cases. Young child, developmental delay, spasticity, and when I examine him, basically I found that he has got sparse hair. So alopecia, basically alopecia areata, basically in these cases, we get the scan done and we found multiple hypertense areas here in the cerebellum, even in the brainstem area over here, and the spinal cord in these locations basically. So absence of hair in a child and having a spasticity, we were well almost around 2-3 months of the age, and then he has deteriorated. We looked for biotinidase deficiency, which is a common risk factor for all such kinds of things. It turned out to be positive, and we put him on a simple tablet of biotin, which cost very, very less basically. And after a couple of months, you look at him basically, he's growing his hairs also, and he had become much more alert and active. He was still following with muscle. So the message is, you doubt CP whenever you get some neurocutaneous stigmata, like sparse hair, or like if you find some kind of like sacral dimple, like as you see in this case basically, and even if they have got some problem of locomotion and posture, but if you find that they have got some sacral dimple basically, these cases requires to be further evaluated, like this child who has got some spinal tough hair basically, because they might be having some spinal dysraphism basically. So whenever you see a child who has got only paraparesis or only paraplegia, the arms are totally normal basically, or a child who has got some bowel bladder involvement, especially bladder involvement basically, or if he has got some scoliosis, or if he has got sensory signs, so you doubt CP in those cases, because normally CP will have, although this is diplegia or tetraplegia or triplegia, depending upon the anatomical environment, but CP per se, because of the nature of injury suffered at the birth, definitely they will have some amount of abnormalities in their arms functions also. They can't be pure paraplegia. Whenever there is pure paraplegia, you think more from the spinal cord pathology than from the brain in those cases. So doubt CP whenever you find that the arms are totally unaffected. This can't be cases of acquired cerebral palsy in that part. This young girl, look at her, she's quadriplegic, she can't move basically, but she's quite active, alert basically. This is not typical CP. CP will having quadriparesis because of acquired insult. As I showed you in the first diagram, they will have a global brain insult, global brain hypoxic injury. So they won't be so interactive, they won't be so smiling, so fixing and following basically. So a child who is quadriplegic and she still has got maintained mentation in terms of like interaction and fixing following. This is also a case where you have to be doubtful about cerebral palsy in this case basically. So like when we examined her further, what we found that she had some basal ganglia iron accumulation, and this is a condition which is called as neurodegeneration with brain iron accumulation. And we have got a couple of these cases. They are not uncommon. Once you start looking from them, you do find them such kinds of cases basically. Other case, a 6-month-old child, history of consanguineous marriage. He was born with neutral encephalopathy, didn't cry well at birth, so labeled as cerebral palsy, and then he was having intermittent seizures by the time he came to me, and I found that he was having definitely global developmental delay with history of poor cry at birth. But when I went into the history, what I found striking was that he had history of 2 siblings expiring in infancy with seizure disorder. That is something which is alarming basically. So these cases with a significant family history and causing expiry, they must be evaluated beyond cerebral palsy. So we got the scan done, and similarly you find there are bilateral significant findings basically. We got the metabolic test done, and it was found to be a case of methylmalonic acidemia, which is still a treatable condition, which is still a preventable condition basically in the part. So you have to doubt cerebral palsy whenever you find significant family history of siblings suffering from the similar kind of illness. Look at this young girl. So and look at the way she's moving her hands. This is constant hand wringing movements. We label them as a case of stereotypy. And this is a child with global developmental delay, labeled as a cerebral palsy, but this was basically a genetic condition. A child with Rett syndrome, where they have GDD along with the stereotypy because of genetic defect. And once you know them, you can prevent subsequent pregnancies having similar kind of children. So doubt CP whenever you got some abnormal faces, regression, you find some stereotypy basically, and if you're finding ataxia in a child. This child also, look at the way he's holding his legs. So alert child, active child, some dysmorphism is there basically in a part, and he's attaching in the way he's holding the legs and holding the hands basically in the part. So ataxia, which is a cerebellar sign predominantly, you should be doubtful in diagnosing cerebral palsy. So as I mentioned to you, hypotonia, nystagmus, ataxia, which are predominantly cerebellar signs, you doubt whenever you find such kinds of patients. This is just a chart which tells you, depending upon a spastic, dyskinetic, ataxic, you can have DDs, a number of DDs basically, and the weakness also basically. So remember, CP doesn't cause weakness. See, a child with CP will be as strong as you and me basically. Weakness is a sign of peripheral neuromuscular problem, neuropathy, myopathy. We find really a child who is weak in terms of grip and getting up, we suspect neuromuscular and not cerebral palsy basically in these cases. Most commonly where you get atypical CP is dyskinetic and ataxic. So these cases must be evaluated for the ataxic and dyskinetic whenever you find predominant signs on that part. And they have done now a number of retrospective studies. This was a study done in the Australia, basically where they re-looked at the diagnosis of CP, which was from 1993 to 2002. So when they re-looked in 2010 of children who were diagnosed in 2002 as a case of CP, so among 402 children, they found that almost 21 children, they were not meeting the criteria of CP. So almost 5% were not CP basically. So what they advise that whenever you find that the child is not behaving, he's not growing as a child with cerebral palsy, he's showing some neurodegradation, he's showing some atypical features like stereotypy or like ataxia or like behavioral problems basically. So you re-evaluate your diagnosis of cerebral palsy. You may find some genetic, genomic or metabolic etiology. That is the message from this part basically. Similarly, it was also a retrospective study basically where they reanalyzed 47 patients who were labeled as a CP. And what they found, once they were labeled as a CP, but they didn't have any particular etiology on the MRI and from the history. And when they reanalyzed, they found that almost in 23 of these 47 patients diagnosed as CP without any apparent etiology, they found a genetic or molecular etiology. And what they found that in 14 of these 23 patients where they found genetic and molecular etiology, they had some specific treatment. So you understand basically almost 1/3 of the patients who were left as a case of cerebral palsy as a dead end had some treatment which was already not given to them. So that is the basic crux. That is the basic message which I wanted to share with you, that don't leave it like a cerebral palsy. So if needed, this should be evaluated further. And the same thing is being seen in this study also. Almost 1/3 cases of cerebral palsy who do not have an apparent etiology at birth or who do not have a significant MRI finding suggestive of CP basically, they could be of genetic etiology and they must be evaluated further in those cases. And we are finding a lot of these articles basically suggestive of that part. What they have found, startling fact is this, there are 67 treatable IM disorders, metabolic disorders, 67, who can be mistaken for cerebral palsy. So this is a huge number of conditions which can be treated, and they are, taken as a case of cerebral palsy basically in the part. So, it's a thing to ponder basically. And similarly, this was a population-based study where they found that in 1 in 3 children labeled as a CP were basically not CP. They're basically having a genetic and molecular etiology basically. So all these things basically say you that CP can be misdiagnosed and they can have some other conditions which may be treatable and preventable. And what is the logic behind, what is the reason behind that there can be some genetic basis of CP? The chances of having congenital abnormality is much higher in children with the cerebral palsy. CP is much common in monozygotic twins as compared to dizygotic twins basically. In family of consanguinity, it's more common. If there is high paternal age, chances of it having is much common basically. And there are certain mutations in the genes, both single gene and multiple genes, which causes CP-like features. So this all means that there can be some genetic etiology apart from penital asphyxia, which makes them more prone to suffer brain malformation, maybe more prone to make them more suffer penital asphyxia at birth. So there can be some genetic etiology underlying all these conditions basically. What is the benefit of knowing all these things, spending so much amount of money, investigations, and exercise. Is it futile? The answer is no. Because I just shown you in the first couple of my cases. Once you find an etiology of the child's global developmental delay, child's problem of locomotion and posture, you give an answer to the parents. You see, this is the cause. Is it because of some perinatal insult like hypoxic ischemic encephalopathy, or was there something antenatally? It means you can prevent it also. If it was because of perinatal insult, definitely you'll go for some other higher perinatal care to prevent recurrences. And if it is because of some antenatal event, definitely you'll go for some genetic, metabolic, and testing to prevent the birth of similar kind of child in the family. It is really difficult to raise a child with cerebral palsy, basically. And if you have got, siblings with similar kind of disorders, you can always think of. You all are trained, and you come across the children day-to-day life, basically, and you can understand how much discomfort it is for the parents. Discomfort is a small word for them, basically. How much difficult for the parents is to raise a child with cerebral palsy. Once you know there is some genetic etiology, we can go for targeted screening of parents. We can go for embryo pre-implantation in the part, basically. We can go for some kind of gene therapy also, basically, in those cases. We are also doing studies at our Gangaram Center about the genetic causes for global developmental delay. Maybe we'll have some study from our center also in couple of years, basically, the genetic causes for GDD in our part. So last couple of slides. When to evaluate further. This is the clinical part, the practical part, basically. First child, practically I always find, if it is the first child, you spend more amount of time finding that can this child have something apart from perinatal asphyxia or hypoxia, giving rise to such kind of symptoms of impairment of locomotion and the posture. Absence of positive perinatal events, significant history of Apgar score, birth records, maternal hypotension, child's problem, basically. If it is family history of similar kind of illness, if you're finding hypotonia, ataxia, ocular abnormalities, involuntary movements, remember this thing, you must look beyond cerebral palsy in these cases, because this is not common in pure cerebral palsy. If you're finding muscle weakness, as I mentioned to you, CP doesn't cause muscle weakness, autonomic dysfunction, sensory findings, think for those parts. Evidence of relapsing symptoms, child was well, then went down, again well, went down, like metabolic. These are typical of metabolic problems, not so CP, basically. If you don't find any etiology on the MRI part, although CP can, 15% of cases of CP, 15% can have a normal MRI part, but this is very, very uncommon. If you don't find any etiology, basically, you have to think beyond CP in these cases. And if you find some developmental malformations on the neuroimaging, definitely look beyond CP in those cases, basically. So facial dysmorphism, as you see in children with the Rett syndrome, Angelman syndrome, think beyond CP in these cases. If you find some optic atrophy, retinopathy, those cases should look beyond CP. If it is a pure sign, as I mentioned to you, because CP is hypoxic ischemic encephalopathy at the perinatal part, that causes global injury to the brain. Although it may be limited more to one part, but it will cause global injury. So you can't have only one signs of motoric impairment. They will have some other signs also, like intellectual impairment, reading issues, behavioral issues, basically. If you're finding only pure sign of spasticity, pure dystonia, his intellect, his intelligence, his behavior, everything is normal, this is something which is unlikely to be cerebral palsy because of his etiology suffered at the birth. He has to have some mixed findings, basically. Pace cavus or pace planners, basically. Evolving sensory signs, basically, in a part. This is not a feature of CP. So whenever you see a child with CP, apart from the thing which we do, the neural part and everything, which Dr. Sinha will discuss with you in detail, basically, what I'm trying to say is that we need to look for anything which is treatable in this case, apart from the neuro rehab part, basically. And can we find a cause to tell them in a better way what is the prognosis of this child, whether he can improve or not part? Can we have a genetic counseling to prevent the recurrence of such kind of children in the future?
Asha. Well, thank you, sir. Thank you so much for such an informative session. We could not continue with the last slide because of some interruption in between. So we'll take the webinar further. Now,
Hello.
Aggressive research is being conducted around the world involving the treatment and prevention of movement disorder. Now, a lot of progress has been made, and children who experience muscle spasms and dystonic posturing due to severe cerebral injury and subsequent neuromuscular involvement, for example, are benefited. Well, I guess sir is there online, so we'll continue with the session.
Uh,
Welcome back, sir.
Hi, I think there were some issues. So
Yes, sir, we'll continue, sir. There was some, I mean, your voice was not audible.
yeah, there are some net
So,
issues basically.
yeah.
So give me a minute. I
Yes,
think,
sir.
yeah. I'm unable to share the screen now.
So open your PPT.
Can you see or not?
No, no, sir. Open your PPT and minimize. Then share screen.
I think there's some issue with the sharing.
Sir, only whiteboard.
Sorry.
Only white screen.
Yeah, so I think there's some issue with the, I don't know why this is again. Can you see? No.
No, sir.
I'm not finding the option of sharing my this one. Only whiteboard is showing over here.
Yes, sir.
No problem, sir. You can continue with, I mean, without screen if you can, sir.
It was last slide. I just wanted to give the same
Yeah.
message. Maybe the same thing. I'll just conclude because we have got Dr. Sinha also to speak. So the message remains clear that whenever we find a child who has got some atypical features means like any facial dysmorphism, family history, features like hypotonia, ataxia, ocular abnormalities. Basically, these cases should not be left as a case of cerebral palsy. We should not, I mean, use cerebral palsy loosely. We must evaluate them further so that we can treat them if there is some treatable cause basically, or we can definitely prevent recurrence of similar kind of things in the family basically. So that's the basic message.
बैठो 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 उधर सामने बैठो ना।
Thanks a lot.
इतना मैसेज बजता है किसका?
आपका बज रहा है।
मेरा मैसेज है।
Thanks. I think we can go to Dr. Sinha now.
Oh. Thanks a lot, sir. Thanks a lot for such an informative session, sir. It was really very nice and it's very, very useful in our profession, sir. Thanks a lot. Now, Dr. Vinay Kumar Pandey, sir, who is a Vice President of IEP Bihar chapter and is Senior Physiotherapist and HOD Physiotherapy Department, and he is also a Gypsy Registrar at IGIMS. Sir will be explaining us about various research aspects in the field. Over to you, sir. Vinay, sir. Vinay, sir, are you there? Well, I think there is some issue. Uh, we'll contact him later. We'll continue the webinar further. Many myths about cerebral palsy persist despite enormous advancing efforts. These myths also put under stress on parents and other family members of children with CP. Many myths like CP is a progressive condition, people with CP cannot live independently, children with cerebral palsy cannot communicate, children with CP are intellectually disabled, CP is same for everyone. There are so many questions, and there are so many doubts in mind. Actually, that has become a mindset of an individual. Now, colleges do not accommodate students with cerebral palsy. A child with cerebral palsy has a limited future. People with CP will never have children of their own, and many, many, many more. So, Dr. Uma Shankar Sinha sir, who is a well-known figure, and he is also a panel member, Selection and Recruitment Committee State Commissioner, Disability, Government of Bihar. He is a member of committee running the old age home, that is Sahara, Patna, Government of Bihar. He is a panel member specification of special orthosis and prosthesis, Social Welfare Department, Government of Bihar. And yes, of course, he is a Corona warrior as he has taken part as a specialist for the PWDs in the online public court by the Social Welfare Department, Government of Bihar during the pandemic of COVID-19. So, not taking much of your time, sir, over to you.
Thank you, Dr. Smita. And really thankful to Dr. Parveen Kumar sir. His very nice presentation. I think it will be very helpful for the rehab professional of the Bihar.
Yes,
And
of course,
thank
sir.
you, thank you, and thank you, Dr. Narendra Kumar Sinha sir, Pandey Rohit sir, and all the IAP technical team, Dr. Vinay Pandey sir, for their presence here. Today, just I am sharing the brief about the cerebral palsy, that its social inclusive challenges and the role of a physiotherapist. Generally, we only focus on their medical rehabilitation. But today, just I am sharing the hidden facts with the cerebral palsy. What are the social inclusive challenges and what will be the role of a physiotherapist? So, the goal of today's presentation is that here how we can bring the inclusion to one of the India's largest minorities, present effective ways of assisting people with cerebral palsy, help us to appreciate the similarities we all have, able-bodied and disability. Without inclusion, people are more likely to experience poor mental health, loneliness, isolation, and poor self-esteem. So the cerebral palsy is not only a disability, it's a cognitive, developmental, intellectual, mental, physical, sensory, or some combination of these, and that affects a person's life activity. Cerebral palsy is an umbrella term covering impairment, activity, limitation, and participation restrictions. So the cerebral palsy is thus not just a health problem. It is a complex phenomenon reflecting the interactions between feature of a person's body and features of the society in which he or she lives. So the global situation of cerebral palsy and other disabilities, that around 150 million adults experience significant disability functioning. In India, out of 121 crore population, 2.68 crore persons are disabled, which is 2.21% of total population. I think it is not fact because according to the WHO, 10 to 12% of the population who are suffering from any kind of the disability. In India, it is cerebral palsy is 3 cases per 1,000 live births is of cerebral palsy, and there are about 25 lakhs CP children in India as per last statistical information. This is the some status of the school attendance of the person with disability in India. Around 27% of the PWDs is never attend the any kind of the institution or the school, and who early join the school, later on they also leave the school. These all are the data of the disabled children 5 to 19 year age of according to the state wise. And the main fact is that the state of UP, Bihar, Maharashtra and the West Bengal together contributed more than about 50% of disabled children of the country. Uttar Pradesh is the number one, that consists of 20.31% of the total person with disability. Bihar is in the second, who consists the 14.24% of the total disability in India. This is the data which has been collected through the Election Commission of India during the election of Bihar. Around 82 lakhs 83,652 people are suffering from disability, but this is also not the true data, because according to the survey of many organizations, many non-government organizations, especially my organization also, we found that around 35 to 60% PWD is not recognized with the government, and they have not the disability certificate. So those who have the disability certificate, they have been calculated into the data. So what is the social inclusion for the cerebral palsy? Inclusion means a respect for you, for me, and for everyone, including see us a person, see that we exist. A socially inclusive environment is one where everyone is welcome, permitted to establish their identity and express their feeling. Social inclusion assures that one's opinion and experiences are honored like anyone else. With the social inclusion, CPPWDs feel associated, are acknowledged, accepted, and recognized for who they are within their community, actively participate in the community, have the right to choose their activity based on their personal preference, have the right to choose their social relationship where they choose and share common interests. People with cerebral palsy faces many barriers in all areas of their life, like education, employment, social and political life, community participation, health. These all are the disabling barrier. Widespread evidence, according to the PWD, that due to inadequate policies and a standard, negative attitude and discrimination, lack of provision of services, problem with the service delivery, inadequate funding, lack of accessibility, lack of consultation and involvement, lack of data and evidence. Social inclusive challenges with cerebral palsy, mainly the difficulties that the people with cerebral palsy with their chronic illness are facing can be divided into 9 major criteria, including loss of independence, transportation, education, employment, communication, social relationship, getting married, accessibility issue. So here the barrier have the negative consequences, resulting there is a lower educational achievement, lower level of employment, higher rates of poverty, poor health outcomes, and resulting death sometimes. Is Mr. Bittu Kumar, he's suffering from cerebral palsy. I think Dr. Parveen have memorized to see, because many years he treated him. Last year he is expired. So the psychological inclusive challenges listed by the cerebral palsy person with disability, like the personal perceptions, lack of self-confidence, low self-esteem, negative body image, the perception of the others, finally sometimes decided to suicide also. So by to minimize the disability, these things can be minimized by the combined coordinated use of medical, social, educational, vocational rehabilitation program. But we only focus on the medical rehabilitation. We never focus on the social, educational and vocational measures. Rehabilitation in India, these are the some rule which had been formed by the central government. That is the Indian Lunacy Act 1912, Mental Health Act 1987, Rehabilitation Council of India Act 1992, Person with Disability Act 1995, National Trust Act 1999, Right to Education Act 2010, and the Right of Person with Disability Act 2016. Here, some brief about these rules. So the role of a physiotherapist, the role of a physiotherapist for their social inclusive, for their social inclusion. Here's how can we bring the inclusion to one of India's largest minorities? Because without inclusion, the people are more likely to experience poor mental health, loneliness, isolation, and poor self-esteem. So it can be a common misconception around the physiotherapist that the physiotherapy is useful in the society also. That physiotherapy is useful only to people who are recovering from the illness or injury. However, the physiotherapy is ideal for supporting the people with disabilities to participate in physical activities that they are interested in. Traditionally, the physiotherapists have supported many people with the disability by helping them overcome their mobility challenges. Here, just the picture of Apna shelter home of the government of Bihar. So how can we, how can the physiotherapists support a CPWDs for their social inclusion? We have done a physiotherapy assessment to look how someone moves around their home and community in their lives. These include assessment of how their body function, such as strength, muscles, joint movement, endurance, or fitness and balance. I can make recommendation that would make moving around at home and their local community easier. They are the orphan children. So the attitude of the cerebral palsy person with disability that teach me skills, don't treat my ills. We know very well that the cerebral palsy is a broad spectrum motor disability caused by the brain damage, and although the disease is non-progressive, but the clinical feature develop and the child grows. And many children in the cerebral palsy who are spastic cerebral palsy, and we know that a spasticity cannot be reduced, it can be managed only. So managed by the prolonged any sports activity, recreational activity. They have even the on Olympics also. Here we organize so many Olympics and the sports activity in Bihar, supporting the people with disability to assess their sports and recreational opportunity in their community, such as team sports, PE lesson at school, local community classes, or the gym program to increase social participation, physical health, and well-being. According to the WHO, World Health Organization, in the recent survey of the people with severe disability shows that between 35% and 50% of the PWDs in the developed country and between the 76% and 85% in developing country received no treatment in the year prior to their study due to financial difficulties, accessibility issue, and lack of awareness. In India, it is about 95% who discontinue their rehabilitations program according to the Ministry of Social Justice and Empowerment. For this, a government has also continued a program that is the Deen Dayal Upadhyay residential rehabilitation program with the central government. And for the awareness, in India, it is about 95% who is continue their rehabilitation program according to the Ministry of Social Justice and Empowerment. For this, the government has also continued a program that is the Deen Dayal Upadhyay residential rehabilitation program with the central government. Social inclusion rehabilitation program in slum area through the community based on the rehabilitation. Firstly, we do the assessment through the CBR program. We identify the children with special needs and aware their parents and the society about the concerned etiology like delayed cry, neonatal jaundice, neonatal meningitis, premature pregnancy, there is a viral infection due to rubella and cytomegalovirus infection, hypoglycemia, breech delivery, and aware the mother about the importance of checkup during the pregnancy and delivery at the hospital for prevention of the cerebral palsy, and coordinate the local health worker ASA with this area. And the identified children with the special needs called to the center for the rehabilitation program and made benefited by the various scheme of the special children by the state and the central government of India, that they can continue their prolonged rehabilitation program without any financial burden. Here we have we regularly do this so many awareness program. This is the social awareness program in the physiotherapy clinic of the Patna. We visited so many clinic of Patna. Aware them that the for the cerebral palsy, Government of India expense up to 1 lakh, spend the 1 lakh per year per annum for their rehabilitation program and medical program, totally free of cost. And government have never discriminated the poor and rich. Any person with disability who concerned or related with the cerebral palsy, autism, mental retardation, multiple disability, they can get the benefit through the National Trust 1 lakh per year for their treatment and rehabilitation program. And it is 100% fact that many cases of the cerebral palsy who need the prolonged rehabilitation, they continue their therapy in the clinic after 6 months, after 1 year, they regularly discontinue. These all are the some social awareness program, Barte Kadam, for the social inclusion of the PWDs, especially cerebral palsy. So we try to rehabilitate them for their each and every aspect of their life, not only for the medical rehabilitation. So here just I'm showing you what is the result of the social inclusion program or the awareness program. She is Sachi. She have taken many years physiotherapy treatment in many clinics of the Patna, but there is a misconception in her mind that I will 100% fit. So before the 4 years back, she come to my rehabilitation center. We assessed and we counsel to her that you can never become the 100% fit, and counsel to her prepared for the National Paralympics, for their recreational work, social work. And after the 4 years, after the continuous effort, she won the 3 gold medal in National Paralympics. And she has been rewarded by the very handsome amount by the government of Bihar also. and watch what are the hidden facts of this Paralympics medal. Because earlier there was a reservation is only 3%, but after the RPWD Act, right, with the Person Disability Act in 2016, Government of India has been increases from 3 to 4%, and there is also a sports quota. And now we Sachi is 18-year-old, and we are just boosting her for preparation of the government job, that the Sachi will live in this society with her equal rights and opportunity in each and every aspect of her life with the social inclusion. So I always believe in the power of words. Many people speak before they think. I know the value of words. The words can make you, break you, they can heal you, they can damage you forever. So I always try to use the positive words in my life, because always people see their disability, but I see their ability. Their disability break them, deform them, but your words can mold them into the best version of their life, and your words can change the DNA. And finally, the Government of India, by the National Trust, Ministry of Social Justice, also published the success story of the Sachi in the main page of the Ministry of Social Justice, concerned with the Astha also. Thank you. Thank you, Dr. Smita.
Thanks a lot, sir. Thanks a lot for such an informative session, sir. It was very important, and I think this is a requirement of society too. Well, now we all are open for question round. If any questions and queries, both Dr. Praveen Kumar and Dr. Uma Shankar sir are available. You can put on your questions in chat box so that those questions could be answered. Any questions and queries can be put on the chat box so that it could be answered.
And there is no questions.
So we'll proceed further.
Yes,
Thanks a lot, sir. While growing up with disability is often challenging, it's important for children to know the realities of their disorder. Those realities don't necessarily involve limits on whom they can be and what they can accomplish. Likewise, parents of children who are with disabilities may indeed face some hardships, but those are not certain and can often be overcome. As we are proceeding towards the new beginning, Dr. Rohit Kumar Sinha sir, who is Joint Secretary of IIT Bihar and working as Assistant Professor, Department of Physiotherapy, Magad University, Bodh Gaya, would come up with vote of thanks. Over to you, sir.
Thank you, madam. Very good afternoon, all. Actually, it's a great privilege and privilege to propose a vote of thanks on this webinar. First, respected and most distinguished resource person of the day, Dr. Praveen Kumar sir, and State President Dr. N.K. Sinha sir, Vice President Dr. Vinay Pandey sir, Secretary of Bihar branch, and also a resource person of the day, Dr. Uma Shankar, State Head IEP Women's Cell, Dr. Smita Singh. Yes, she's very dynamic. Office bearer of the IEP State branch, eminent faculty members, and beloved colleague and lovely students. My first gratitude to distinguished speaker, Dr. Praveen Kumar Sinha, Praveen Kumar sir. This the way you have shared your knowledge and experience with us. Definitely, it will enhance our skill and knowledge too. Uh, Thank you very much, sir. You took the time out for us. I know you are a very biggest person, and right now the country is facing a different kind of issue. The doctors are the most demanding person. This time you have took the time out for us. Thank you. Thanks a lot, sir. I hope in future we'll interact. We will learn from you and the different aspect and different issue on different issues. I would like to thank the other resource persons of the today the webinar, Dr. Uma Shankar Sinha, for their nice presentations and what is the legal aspect of the disability, and apart from the treatment area, how we can help the person who are facing the different problems. The most important thing, the economical aspect, and how we can help him out. That those childs and those persons who are suffering from the disability. Thank you, Uma. Your presentation was very nice.
Thank you, sir.
And most important thing, you have also discussed the legal aspect and how he can get the benefit from the different the trust who are working in the society. Our special thanks to the state president, Dr. Narendra Kumar Sinha, sir, for your welcome speech. I would like to mention one thing, sir. Your presence is a big motivation for us. Thank you, sir, for taking time out for us. Sir. And you also discussed with the current scenario, the situation of the state council as well as the central council. And sir, I know, sir, you are a dedicated person, or you are the only person who are working behind this scene and doing everything or putting everything. Sir, my special thanks to you, sir. I'd like to express my gratitude to Vice President, State Branch, Dr. Vinay Pandey, sir, for their support whenever and wherever it is needed. Thank you, sir. Actually, we missed your session, sir. Actually, you are a faculty person. You are involved in the educations also. So we are expecting something deserved that just like the Dr. Singh, madam has discussed about you. He will explain the current scenario about the research. And due to the inability or something like that, we missed your session, sir. But I hope next time you will discuss these things or about the research development and research in the field of research. And I would like to thank the state head women cell, Dr. Smita Singh, and their team, because it can't be successful without you, ma'am, and your efforts. Your special thanks to everyone in your team. At last but not least, I'd like to thank the physiotherapy professionals and the students who have joined this webinar. It can't be successful without you, without all of you. Thank you so much for joining us this webinar. At last, I'd like to thank the IAP technical team for their technical support. At the end, I thank you all, and once again, have a great evening. Over to you, Dr. Smita Singh. This is from my side.
Thanks a lot, sir. Thanks a lot. Well, it might be stormy now, but rain does not last forever. Don't take your health for granted. Don't take your body for granted. Do something today that communicates to your body that you desire to care for it. Tomorrow is not promised. Take care of yourself. Thank you. Thanks a lot. Hope to meet you again.
Thank you. On behalf of IAP technical team, thank you Dr. Praveen Kumar sir, Dr. Uma Shankar sir for this wonderful session and all the participants for attending the webinar. I would also like to thank our IAP President Dr. Sanjeev Jha sir and IAP WC National Head Dr. Ruchi Vashni ma'am for providing a platform for sharing a knowledge. I request to all participants, please subscribe our YouTube channel and follow our Facebook page. Thank you so much. Thank you.
Thank you.